and thanks so much for joining us today on today's webinar around suicidality and autism. My name's Rebecca Sterry. I'm Director of External Affairs at Autistica, and I'll be your host for today's webinar. I'm going to be joined by Rachel Moseley, Mirabel Pelton, and Georgia Harper. Georgia has pre-recorded her talk for us today, so she won't be available for Q&A, but our other two speakers will be. But first of all, I want to just introduce Autistica for those of you who don't know who we are. So we're the UK's leading autism research and campaigning charity, and we exist to ensure that all autistic people live a happy, healthy, and long life. We work with autistic people, we fund and carry out research, and we shape policy to make sure that evidence generated through research makes a real difference to people's lives. A big part of that is sharing the latest research and evidence-based best practice, and that's what these webinars are all about. So we know that today's topic is a really difficult one, so please do take a break at any point if you need to, if the topic gets difficult. The session is recorded, so you can catch up at any point. And also, you might want to take out some time after the session as well. And if you need to speak to someone, please reach out to a trusted person. We can always contact the Samaritan if you need to speak. So today's session is in two sections. Our speakers will talk initially about what we know so far, and then they'll have a short Q&A. And then we'll move on to the second half of the session, where they'll be focusing on their current work and plans for the future. And then we'll finish with a Q&A as well. So I'm going to stop talking now. I'm going to hand over to Rachel and to Mirabel.
Just to say, it's an absolute pleasure to be here this afternoon. Thank you to Autistica for inviting us to present this afternoon on this occasion of World Suicide Prevention Day, which was on Sunday. We're going to be thinking about suicide prevention for autistic people, in particular what we need to do differently. And just to reiterate the notes that were just shared there about caring for yourself, looking after yourself as we're talking. Both Rachel and I are both open to be contacted directly if you prefer to speak to us rather than to listen to this webinar. So, and again, this webinar is in two parts. To reiterate that here, both Rachel and I will be talking about what we've learned from theoretical research and then ongoing research that we're involved with and future research directions to provide better support to autistic people. We are going to give you the opportunity to share your views using interactive features in this webinar. This is anonymous, this is optional, it's not research, and we won't be storing or using the data, but it's really helpful for us as researchers to get an idea of people's views on this topic, but it's completely optional and up to you if you'd like to take part. So, moving on to the substance of what we're going to talk about, we know that autistic people are more likely to die by suicide than people who aren't autistic. The figure on your screen is the proportion of people in a recent psychological autopsy study in 2 local authorities in England that had evidence of autism or possible autism when they died of suicide. And that is versus a prevalence of autism of 1 to 2% in the general population. Then we also know that autistic people report that services do not meet their needs and that therapists can lack experience and knowledge of autism. And overall, this can make people feel disbelieved in their distress and make people feel worse rather than better. We know that there are no evidence-based supports available. And one difficulty could be that the way that we conceptualise, understand, measure, think about and describe suicide doesn't describe the experiences of autistic people. So this is the way where the research comes in that I've done in my PhD. So this is the first set of studies that I'm going to give a quick overview on today. It's the first attempt to check whether a leading model of suicide is similarly accurate in the way that it describes suicide for autistic people compared to non-autistic people. So the theory that I'm talking about is the interpersonal theory of suicide, which I felt resonated with the experiences of autistic people. It places unmet social needs at the heart of suicidal thoughts and behaviours for any population group, describes those unmet social needs as thwarted belonging, an enduring absence of giving and receiving reciprocal care in relationships, and a perceived burdensomeness, which is the belief, even if it's untrue, that other people would be better off without you, that you're not making a valid contribution. The important word here is perception. The person can believe that about themselves, without it being the case. Now, the theory argues that other risk factors such as relationship breakdown, unemployment, mental health difficulties, or personality traits can increase the likelihood that an individual will experience either of those. And so in my research, we tested in autistic and non-autistic people whether autistic characteristics, in fact, we found exactly that autistic characteristics are associated with suicidal thoughts and behaviours through these two through these two factors, through feeling like you don't belong and through feeling like a burden on other people. So this is really important because this suggests that it isn't autistic characteristics in themselves that are leading to suicide, but the way that society is reacting to autistic people that's creating the difficulties or not providing them with the support or the opportunity to connect with people. And this suggests that for suicide prevention, it's really important that we avoid these experiences, that we promote opportunities to connect, that we promote full belonging and participation in society, full employment, and fully appreciate the worth of autistic people. However, we also found a significant difference, and I'm hoping you can see this as a marker on the screen. These two sections of the model were significantly weaker for autistic than non-autistic people. And so that means that whilst these two factors are significant in suicide for autistic people, they're not as significant as they are for non-autistic people. So this is our first suggestion that something different is going on. So, and that we need to think differently about suicide prevention for autistic. So, this is your first opportunity to get involved. I just advanced the slides. Given that what you've just heard in the slide there, we'd like you to think about the factors that you think are important for suicide prevention for autistic people. You can take your smartphone and scan this code or go to menti.com at the top of the site, and you can submit 3 words that you think are important for suicide prevention for autistic people. And then on the screen, it should generate a word cloud to all the responses that people have contributed. Now, you might want to agree with the theory that promoting belonging is really important, that promoting employment, independence, autonomy, or you might want to say that other things are important. Now, so you have the opportunity now to enter any words or comments that you want to make in response to that question. And we're going to leave the word cloud running throughout the presentation. Right, this is wonderful. So understanding is there, biggest, right at the center of the word cloud. So thank you so much for everybody who has taken the time to put their views in here. And we can see that some of the theory is definitely upheld here. Belonging, empathy, community, understanding, inclusion, acceptance. These are all really important things that can be achieved through autism acceptance. I can't read smaller ones from here, but we'll definitely have a look at this. Inclusion, compassion, validation. So these are all really important aspects of deep fundamental attachment and connection to others. Okay, so I'm going to go on from the word cloud, but if you can enter this as many times as you want, so if as we go through the presentation, we will be revisiting this. So if that's something that you think is important, if you have a new idea, then please do feel free to come back to the word cloud and enter it, and we'll have a look at it at the end, and maybe this will be downloaded and shared with the resources. So, as I was saying, what I found in that first paper was that the way that the model appeared to be less accurate for autistic than non-autistic people. And so this could suggest that other factors are more important, but it could also suggest that the way that we measure and describe belonging may not be fully meaningful for autistic people. So, in fact, I should have said the way we measure belonging and burdensomeness is not meaningful for autistic people. So, in fact, I tested that statistically, and I found exactly that the questionnaire that is validated and recommended to use with the interpersonal theory of suicide doesn't provide the opportunity to accurately compare scores of belonging and burdensomeness between autistic and non-autistic people. So I've only included the results in relation to belonging on the screen because I felt this one was particularly important. So overall, we shouldn't be using all 5 items to describe a belonging for autistic people. But when we look at the individual items, in fact, we find the first 3 items, belonging, having caring, supportive friends, and feeling disconnected, operate similarly for autistic and non-autistic people. And it's these 2 bottom items which operate differently for autistic people. And this suggests that belonging is actually a fundamental human experience shared by everybody, but that it might look different in autistic people. And this might help us challenge unhelpful past assumptions about autistic people, that they prefer to be alone. The evidence doesn't suggest that. It suggests belonging is similar, but might look different. And the final, model that I'm going to propose to you here is an analysis that I did to look at whether other risk markers might be more important for autistic people. So I wanted to explore the role of anxiety and depression, and I did this using a novel technique called network analysis. Now, I use this technique because it allows us to look at how each individual experience, such as having difficulty with sleep or feeling like you don't belong, interacts with each other individual experience. And I was hoping that this would mitigate some of the difficulties that we know that we have from not being able to compare total scores of, for example, belonging or burdensomeness. But actually we know the same about anxiety and depression, that the way that these scales work isn't meaningful to autistic people. Now, I'm not going to go through the whole analysis, but what we did was to use the network model. We worked with the advisory group and developed a conceptual model here, which demonstrates again, which is the first conceptual model that's available. And the way that we understood what the network was suggesting was that stresses in the environment here, which our model only included feeling like you don't belong and anxiety, can lead to somatic experiences such as sleep and appetite difficulties. And those, if unchecked, if unsupported, can lead to warning signs for suicide, such as statements of hopelessness, failure, and then ultimately to thoughts of suicide and self-harm. Now, I present this model to you with caution because actually the other analysis that we did still suggested that this model was less accurate for autistic than non-autistic people. And the reason for that is likely to be because even though we had gone beyond the scale totals, we were still using individual items that were devised to describe the experiences of non-autistic people. So we know, for example, that for an autistic person, a change in the pattern of sleep may be more indicative of a change of mood in the simple presence of a different sleep pattern compared to non-autistic people. Now, that is rather a whistle-stop tour of those. The last thing that I did want to mention is that I wanted to flag up the autistic people who have collaborated with me and worked with me in this study, and just that I'm preparing an evaluation of the impact of that group. So the impact that taking part in that group had on the individuals, the research, and the researcher. And I wanted to do this because I felt it's really important that we are transparent and accountable for the way that we're working in partnership with autistic people. It's really important, I think, for suicide research that we do have partnership, given the limited evidence base that's available. So overall, I found the impact was positive for the research. We have many, many changes that I was able to document that were made to the research and the research outcomes. We shifted the study focus, methods were accessible, the interpretation of the study results was perceived as meaningful. The advisory group reported their involvement was positive. And for me, and in particular, bringing better outcomes for autistic people and building trust between researchers and autistic people. And for me, as an early career researcher, their improvement was fundamental in building my own knowledge base and the confidence in my research. So I think it's a really important foundation for any doctoral researcher. So try to summarize what I've meant, what I've presented just here now, ever so quickly, I'm afraid. We know that belonging is important. We know that this so it's really important to promote autism awareness, autism-friendly spaces, to understand autism through the double empathy problem, that belonging may be presented differently. We understand some of the warning signs for suicide, and we understand the importance of context reducing stresses in the environment, and working in partnership to deepen our understanding. But mainly, we also know that we need to think differently about suicide prevention for autistic people. And in the second half, we'll be talking about some research in process to do that. Now, thank you for listening. Copies, I think these resources will go out with Autistica, but just to thank everybody who took part in that research that was promoted through the Discover Network. And I'm going to hand over to Rachel now, so I'll stop sharing.
Thank you, Mirabel. So I'm going to attempt to start sharing now. And I'd be very grateful if people could tell me if you can see my presenter notes. Fantastic. So you can just see my full screen. Wonderful. So just to say, like Mirabel, I'm so honoured and happy to be here today, given the topic. But I'm very, very glad to. We're really glad that we can be here with you to discuss this important area. So I'm Dr. Rachel Moseley. I'm based at Bournemouth University. I'm a researcher in psychology, but I'm also a late diagnosed autistic person. So what I'm going to be talking about today is really following on from what Mirabel was saying, reviewing just a few of the findings from my own research, but also thinking about whether there's any implications that we can take from wider research on suicide that might not come from autistic people. Maybe lessons we can learn, avenues we can look down if they might be helpful. Now, Mirabel and I both approached studying suicide in autistic people. We wanted to understand it, and we both approached that from a very similar angle. We wanted to kind of tie in observations of suicidal behaviour in the real world to psychological theories of suicide, to join up the dots, so to speak. The theories of suicide are useful because they can tell us what factors increase the risk of suicide, and they can also tell us why that is. That can give us an idea of what feelings and life events we should try to help people with if we want to reduce their risk of suicide and save lives. And in the general population, psychological theory has actually led to evidence-informed practices in, for instance, emergency responders and interventions. So in theory, looking at psychological theories of suicide seems like a good place to start. And I really identified the interpersonal theory of suicide for the very same reasons as Mirabel. It seemed like a theory that might be relevant to autistic people. And it's a very influential theory. So the theory seems very simple in principle. It suggests that people, there are factors that give rise to feelings of suicide ideation, i.e. the desire to die, and there are factors which make it possible for a person to overcome these evolutionary drives to end their own lives. Mirabel mentions these two states that the theory says are important for suicide ideation. That is, the perception that you are a burden or a liability to others, and thwarted belongingness, which is a state of loneliness, disconnect from other people. But a key aspect of the theory, which I spent a bit more time looking into, was something called acquired capability for suicide. The theory suggests that people become capable of lethally hurting themselves when they experience traumatic events, or events when they experience a lot of physical pain and hence become habituated to it. Essentially, they become less frightened of death and hence less frightened of the pain involved in a suicide attempt. Intuitively, the interpersonal theory of suicide seems to make a lot of sense in autistic people because we typically experience a lot of life events which can make us feel worthless and like we don't belong. Many of us struggle to make and keep friends, romantic relationships. I know this was a big factor for me. We're often bullied or abused. we can struggle with employment, we can be quite dependent on our families. There shouldn't be any shame in that, but it's easy to feel it. So, like Mirabel, my research suggested that these states might be important for autistic suicide, but not in quite the same way as the theory suggests. So, my research, for instance, suggests that only feelings of perceived burdensomeness were relevant to suicidal feelings, and these were also relevant to suicide attempts. Thwarted belongingness, in the way measured by the interpersonal theory of suicide, was actually not relevant for suicide in my participants. But it's possible, likely, that since autistic adults suggest that loneliness is a major factor in their suicidality, it's more likely that maybe the theory just can't properly capture that in the concept of thwarted belongingness, which was, of course, based on neurotypicals. And Mirabel's excellent work has indeed shown that autistic people don't resonate with this concept in the same way. So, overall, my work suggested that these things may be a factor, but they don't explain very much. They only explain a small part of the picture, and they don't seem to work or to be thought about in the same way in autistic people. What about that other concept, acquired capability? So my research showed that autistic people were less frightened of dying by suicide. They tended to mentally rehearse suicide plans more, and these are both signs that they had acquired capability for suicide. Having these signs did predict suicidal behaviour, so those autistic people who were less frightened of death were more likely to have attempted suicide in the last year. I also found that certain behaviours and experiences seem to relate to autistic people acquiring this capability for suicide. So, for instance, if you've experienced a lot of traumatic events, if you've engaged in self-harm, this is in line with the theory of suicide because it suggests that hurting yourself physically gives you greater tolerance for pain, makes you less frightened of pain and death. So my research did find that autistic people who had experienced traumatic events and or self-injury were at higher suicide risk. And this was partly explained by their seeming to have this acquired capability for suicide. That all said, having acquired capability for suicide was a weaker predictor of suicidal behaviour in autistic people than non-autistic people. What this means in practice is it's less reliable as a sign of whether or not someone is at risk of suicide. So many of us experience suicidality, and only some of those people will have this acquired capability. So again, we're not getting the full story in this theory that was never designed for autistic people. If we ask autistic people what factors were important in their suicide attempts, we can see experiences that are suggestive of perceived burdensomeness or thwarted belongingness. So we saw those in your responses that you just gave us in around of belonging, empathy, validation, and so forth. And you can also see these here in answers from participants in the study of mine. They talk about feeling worthless, unrequited love, loneliness, feeling rejected. But we actually also see factors from a number of other theories here. So theories that haven't yet been investigated in autistic people. Hopelessness is a major factor in another psychological theory, which suggests that people attempt suicide when immense pain and hopelessness overcome the factors which might otherwise keep them invested in living. We really haven't investigated those factors in autistic people. You also see here people talk about being ground down, nothing working out for me. And another theory highlights the importance of helplessness, feeling trapped trapped, humiliated, defeated. But as Mirabel touched on, and as I'd agree, what's really obvious in psychological theories is that they are usually very focused on the person. Thwarted belongingness, perceived burdensomeness, and so forth. They are feelings you experience which make you unwell, so to speak, and lead you to the point of wanting to end your own life. So the abnormality, so to speak, develops in you, the individual. These theories don't really think a lot about the environment you grow up in, and for autistic people, this just doesn't make sense. Feelings of not belonging, for instance, have a real basis in stigma, which we know objectively exists in the world. These feelings don't develop in a void due to some abnormality in the individual. Autistic people are a minority group who are exposed to many negative life events. So we need to be looking for answers outside of what's going on in their heads and trying to change the climate people grow up and live in. This was really shown in a recent study from Cambridge, where they found a relationship between autistic social differences, depression, and suicidality. And what seemed to be happening was that the features of being autistic leave individuals vulnerable to abuse and social victimization, such that they accrue childhood trauma. And a lot has been written about the later life impacts of adverse childhood experiences. We know that trauma changes the nervous system. It makes people perceive life as more stressful, and it makes them more prone to mental illness. So research does support that a lot of the things that happen to us contribute to suicidality in autistic people, bullying, for instance, and unemployment. But it also suggests that these things might be more likely to impact us in a severe way. We might be more negatively affected by such life events. These are, for several reasons, features that are common for autistic people. So things like we struggle with cognitive rigidity, repetitive thinking, means that we're more likely to get stuck on distressing thoughts. And it means that it's hard for us to come up with a new approach to a problem or a new way out of a situation. This difficulty is really compounded by the social isolation that many of us experience. It means that we're less likely to be able to access help. We might not have someone to talk things through with. And sometimes when you can talk things through with someone, it can help you to come to a different perspective. It can help you de-escalate. So if you're missing that, that's really difficult. Another relevant factor is alexithymia, a difficulty identifying your emotions, which leads to difficulties regulating them. And alexithymia and emotion dysregulation are a major factor in many of the negative outcomes experienced by autistic people, particularly poor mental health. Again, having these difficulties means that it's very hard to de-escalate after stressful events. And this prolonged stress affects your nervous system and increases your risk of mental illness. Broader research on suicide tells us that we really need to take a longitudinal approach to this, as suicide risk is made up of what we call distal and proximal factors. So distal factors are more stable dispositional factors. They're like far away, pre-existing vulnerabilities for an outcome. For instance, I might be genetically prone to diabetes if I eat a lot of sugar, whereas someone else can eat as much sugar as they want and they won't develop diabetes. Likewise, if I'm born autistic, I'm more likely to be bullied. It isn't a certainty, but I'm more likely to experience that. Then there are our acute events or crises, which we call proximal risk factors, triggering events close to the present day. Say I lose my job, which links into those psychological factors we've mentioned before. So if I lose my job, I have to depend on my parents, I lose my support network. I might experience thwarted belongingness, perceived burdensomeness, hopelessness, feeling trapped in my circumstances. And in these circumstances of close, triggering events, this is where those distal risk factors related to being autistic might kick in a way that makes my suicide risk considerably higher. So say I've been bullied, I've got low self-esteem that I've been living with all my life. That might then really flare up in this situation of crisis. And likewise, if I struggle to regulate my emotions, I might be more affected by the crises. I might have been living with these things, difficulties regulating my emotions, low self-esteem. I might have been living with them as risk factors for suicide, but they don't necessarily kick in a big way until I'm triggered by a very acute recent crisis. So newer theories of suicidality suggest that these distal features, like being autistic, can affect how quickly and easily people transition in and out of crisis states. What they tell us is that this transition can be fast if the perfect storm of factors occurs, and it can be very fluid. For instance, I might experience a crisis where I have suicidal thoughts and a suicide plan, but I don't act on it. However, if this happens a few times, despite the fact that I haven't acted on that plan, it suggests that I can snap back to that plan and these thoughts more quickly if the situation arises in future. So these are all implications that we get from wider theories and research on suicidality, but they really haven't been investigated sufficiently in autistic people. But what we are learning is that suicide attempts cannot be predicted by any one risk factor or any combination of factors. This means that we all have risk factors that are individual for us. For instance, if my self-esteem is very dependent on a relationship, then splitting up with my partner is going to be a huge trigger for me. If you're someone who gets self-worth from excelling at a sport, then a physical injury, which puts you out of action, will be really triggering for you. So the kind of crises which trigger suicidal thoughts will differ from person to person. So it's likely that support also needs to be personalised. I'm going to stop here. It leaves us with the really important questions around how we move on from here and what we do to help. And I'm hoping we'll have some good discussion and we'll also talk a bit more about this after the break. Mirabel and I just want to highlight and thank our collaborators who have helped us with this work, and also our participants who were so generous to give us their time to talk about these difficult topics. And finally, we want to recognise and remember those who are gone and their loved ones who have been bereaved, who are always in our thoughts when we're doing this work. We want to thank you so much for listening. I've linked to my site where you can get accessible versions of this research. So you can use the QR code or just go to the page there. And you're also very welcome to contact me with any questions. But we'll hopefully answer a nice lot of them now during the talk. Thank you.
Thank you so much, both of you. So we're now going to have a very short Q&A before we move on to the second section. And any of the questions that we don't get to this time around, we could potentially answer at the end. So we're aware quite a few questions have come through. So thank you for sharing those questions. Someone's asking on the chat about a recording. The question's still ongoing, and we are going to be publishing a recording on our YouTube channel. So if you missed anything, sorry, it will be recorded and shared either at the end of this week or early next week. So a question that I'll put to both of you, and it's about assessing suicide risk. So can you suggest any research, any tips or any tools for assessing suicide risk in autistic?
Do you want to start, Mirabel?
I'm happy to start. I don't know much about it, but I'm happy to share what I do know. Do you?
I'm likewise.
Okay. So in that sense, I don't know of any suicide risk assessment tools that exist for autistic people. I do know about a I mean, there are the work that has been done is the revision of the Suicide Behaviours Questionnaire Revised that's been done by Sarah Cassidy, which does, I mean, it is a suicide, it does include a measure of suicide risk, but it's not a suicide risk assessment tool. I think I'm assuming that the questioner is asking, and do correct me if I'm wrong, because the presentation of suicide risk might look different in an autistic person compared to a non-autistic person, and this has certainly led people to report feeling overlooked, misunderstood, not taken seriously in crisis. I was part of a sort of working group that looked at warning signs for suicide in autistic individuals, I think that was called. That was led by Lisa Morgan, who is an amazing autistic suicide prevention advocate, trainer, expert, a really inspiring person to work with. And a copy of that warning signs guide is available on my website. Do you want to add anything, Rachel?
I will, if that's okay. I was really going to refer to the same resources you've mentioned, Lisa Morgan's, and I think just to reiterate what you said, I will give you a link. I'll put a link right now in the chat, because I've collected resources together around information around suicidality, but also tools for professionals. But following on from what Mirabel said, there really isn't a lot that is very strongly, robustly ratified by research. That's a tricky thing. And so it's really important to know that although people are beginning to develop measures, and they're good measures, they just don't have lots of research backing them up. So you can never be complacent, I think, is the thing.
And I think some of that is echoed in research in non-autistic people, that suicide checklists and risk checklists are really not at all valid, and that clinicians' skill and personal relationship with their client is really, really important. I think we always report it when we're talking about suicide in autistic people to take a personalised approach. But I think that is, good practice in general, but definitely particularly important in autistic people.
That relates to what you're saying about, what that individual, what value is brought to that individual by their obviously relationships and things like that, as you say, that personalised approach. Thank you. I've got another question here around meltdowns. So where does the meltdown factor into the model? Person here said that post-meltdown has been shown to be a high risk for suicidal ideation. Do you know anything about that?
You want me to start, Mirabel? I think in general we don't know enough about it, but I think there's several elements in there. So burnouts they're associated with a lot of risk factors that have been linked with suicidality. So while there's sort of a little bit of evidence base growing around the relationship between burnout and suicidality, it's not totally clear what the nature of that relationship is. So to explain what I mean, we've seen in research that camouflaging is associated with suicidality. We don't know if camouflaging is associated. It's probably partly associated through burnout, because of course camouflaging is associated with burnout. We also know that burnout is associated with feelings of depression, overwhelm, exhaustion, and these things are also linked with suicidality. So you're absolutely right that burnout is a really important part of the picture in autistic suicidality, but we don't yet quite understand how it relates, and it might differ from different types of burnout. For instance, if your burnout is very camouflage related, you spend all the time camouflaging. Work from Sarah's lab Sarah Cassidy has shown that Mirabel camouflaging relates to feelings of thwarted belongingness and perceived burdensomeness. So it can kind of intensify those feelings that you're not okay as you are. So again, burnout is definitely in the picture, but we're not quite sure how and in what way it relates to autistic suicidality. I might hand over to you, Mirabel, if you want to add anything.
Only to, I wonder, in fact, I was going to sort of ask you, Rachel, whether it's been mentioned in our research about the association, harming yourself during a meltdown. So I don't know if that...
I'm sorry. Can I speak back on that? I'm so sorry. I misheard the question. Meltdown. Sorry. Yes, meltdowns. I guess what I would say about that is what I would imagine is very similar in that if you struggle a lot with meltdowns, you probably struggle with your mental health. You probably struggle with, you're more likely to perhaps feel disconnected from society because, for instance, if you have a meltdown and it kind of, the consequences of that might be that you feel more distant from people, or it has a social consequence that you suffer afterwards. It might again increase that distance from that feeling of distance from other people, and as Mirabel said, some people do hurt themselves during a meltdown, and there may be that link with self-injury. So I think absolutely meltdowns are relevant, and they also are another way that we can feel different, and feeling different seems really important. Sorry, Mirabel.
That's okay. I mean, I thought it was, I think, in terms of the theory we've both looked at, if you were to model it theoretically, you would find that meltdowns contribute to all three components: feeling like you don't belong, feeling like you're not worthwhile in society, and increasing the likelihood that you harm yourself or frighten yourself. Now, whether that explains the full picture, I don't know, because I don't think we really have a clear, we haven't defined exactly what a meltdown is. But actually, I think that the point is, I think bringing in burnout is really important because it's a universal, it's a sort of fully, it encompasses so many things for autistic people that it's actually really important and unlikely to be a simple one-off relationship. I think the model that Rachel just talked about how distal factors influence your individual vulnerability is probably a really helpful, meltdowns and burnouts are probably very individual experiences based on a whole wide-ranging, life-encompassing range of factors that I think we would find a model like the one we've presented oversimplifies.
Thank you both so much. Now, I know there's a few questions that haven't been answered, but we'll either get to them at the end, or Rachel and Mirabel have really kindly said that they would respond to people after the session as well, so we can respond to you individually by email if it's obvious who asked the question. So we're going to move on to the second part of the webinar now. We'll again have the Q&A at the end. So I'll hand back to our speakers.
Okay, I'm going to speak. Rachel, are you introducing something first?
My apologies. Yes, I am.
Yeah, my apologies too. I forgot.
No, this is what happens, everyone, when you get nervous. So, what I'm going to do is I'm going to introduce another bit of audience interaction. So, I invite you all, let me put my screen on presenter view. Just let me know, everyone, if you can see my notes. No notes. Brilliant. Okay, so I'm inviting everyone, and again, entirely optional, but we would love to hear from people around their ideas of what kind of things might be helpful for autistic people who are experiencing suicidal thoughts. And I've seen in the chat that several people have asked for tips, advice, things we can do. And we want those things as much as you do. And And hopefully we're in the second part of this webinar, we're going to be focusing more on future directions for understanding and preventing suicide. But we'd really like to make some space here for your ideas. We would love to hear your ideas, suggestions of things that might be helpful for people who are experiencing suicidal thoughts. And they can be all kinds of things. You can suggest maybe a support service you think would exist, psychological interventions you think can be helpful. You can talk about things that should be changed in order to help people. And we'd also love to hear about your own experiences of anything that helped you. Might be coping strategies. You might have words of empathy and advice that can help other people who are looking at this board. We'd really love to hear your thoughts. So you can just go to the link you can see there, or you can use the QR code. And you can post on this board whenever you want. It will stay open after our session is finished. So you can keep on adding your ideas, and it might be really helpful for us all to be able to see that. So I'm going to move on now for my talk, the second part. So much needs to be done in this area and so much needs to change that it's really hard to cover it all in this little bit of time. So I'm just going to cover a few important angles and messages. First one is so obvious that it hardly needs stating, but autistic people are the vital stakeholders in any and all work around autistic suicide. So researchers need to work with autistic people to understand suicide and to work with them in coming up with ways to prevent it, whether that's new support services or how to change existing structures. I'm part of a big collaborative project with the Autism Centre of Excellence at Cambridge and researchers from several universities, and we're soon to be launching a survey to ask autistic people for their ideas about suicide prevention. So please look out for that. Yeah, you're welcome to drop me an email if you want me to send it to you. Though if we're also hoping to be able to distribute the survey through major autism organisations. I should say, I realise at this point that I've skipped the order, Mirabel, and I was meant to transfer back to you after sharing. So really sorry about this. I will finish my talk and then I will hand over to you.
That's absolutely fine. Go ahead.
So the second thing I want to say is that most research on this topic looks at people at a single point in time. It takes a snapshot of your current state, so to speak. The problem is, this isn't how suicidality develops. It's a process, a trajectory, and things that happened a long time ago can, in the perfect storm of circumstances, contribute to suicidal feelings later on. We really need to understand more about this, about the trajectory of someone's life up to the point where they develop suicidal feelings. However, in line with thinking about autistic suicidality from a life perspective, we also need to know where the risk factors for suicide change over time. We're very different, aren't we, when we're 15 versus when we're 50? We have different hopes, different desires, different things that cause us stress. It stands for reason that perhaps some of the most important factors in suicidal feelings for autistic people might not be the same factors across your whole life. So when you're a teenager, those things might be different from suicidal contributing factors in middle age and older age. Part of my research is looking at menopause as a potential crisis point for autistic women and people with ovaries. It seems to be a point of massive change, a bit like puberty, and it can be really disruptive. However, this highlights the general importance of considering intersectionality and variation across the autistic community when it comes to suicide risk. There might be different risk factors for people based on things like sex or gender, whether they have additional marginalised identities, ethnic minorities, and so forth. And something that one of the best quotes I've heard on this topic, again from the amazing Rachel Moseley, such an important comment, is that understanding autism and the culture of autistic people so that autistic people don't need to mask or camouflage their autism is suicide prevention. So what she's saying in some regard, I believe, is that this is a social, societal problem, and we need societal change. High suicide rates in autistic people don't come from a void. Researchers and professionals need to badger and chip away at the government to make change throughout the different levels of society. We need educational systems where autistic children have equal opportunities to thrive and grow up with good self-worth, knowing they're valued for their own unique selves and what they bring to the world. We need jobs that are well suited for neurodivergent people, and we need neurodivergent people to be supported to obtain and maintain those roles in workplaces that are safe to be autistic in. We need health and support systems that are autism affirming, non-pathologizing, where people get appropriate support when they need it. We need timely diagnostic services and post-diagnostic supports for all of us who grew up believing that we were broken or deficient, since mental health and suicidality really seem linked to late diagnosis. And these are all different areas where we need to keep chipping away because they all contribute to suicide prevention in terms of helping autistic people to be happier and healthier. And I was going to present Autistica's video at this point, but what I think I'll do instead is we'll hand over to Mirabel, who's going to talk about the research he and her lab are doing, and then we'll come back to Autistica's video. So please go ahead and share your screen, Mirabel.
Right, I hope everybody can hear me this time, and I will try to share my screen. Right, hopefully everybody can see that now. So I was just going to talk about two studies that I've had the pleasure to be involved with that have both looked at improving our understanding of suicide amongst autistic people and suicide prevention. So the first one is a study led by Dr. Sarah Cassidy, where we have used the card sort task for self-harm to explore patterns of self-harm in autistic adults. And we're doing this because we know autistic adults self-harm 3 times more often than people who aren't autistic. We know that that self-harm has traditionally been overlooked as a suicide risk factor amongst autistic people, conceptualised as a challenging behaviour associated with intellectual disability, and we know there are no evidence-based interventions to support autistic people who self-harm, and we know that it is a significant indicator of future death by suicide. So the card sort task for self-harm is a task originally designed for non-autistic young looked-after people. It contains 117 cards, each of which lists a thought, a feeling, an event, a behaviour, a support or service that could be significant in an experience of self-harm. And participants place time points from the point of self-harm back into their past 6 months ago and before 6 months ago, exactly indicating that sort of balance of proximal and distal risk factors that Rachel was referring to. And then participants can select as many or as few cards that are relevant to them to place them under the time point in order of importance. And the important point here is that people can also take a blank card and write something on there that was important to them. And so this task has been found to be really helpful in young people to understand patterns of self-harm, to start and scaffold difficult conversations. It has a lot of visual prompts and low verbal demands. So this is a two-stage study. I'm trying to move forward. There we go. So the first stage of this task explored the possibility of adapting the card sort task for self-harm, which is called the CATS, with autistic people and those who support them. It found it could be potentially useful. The study began recruiting participants just before the pandemic. When we returned to work after the pandemic, we offered participants the option to attend the office to do the research in the traditional manner, or to take part in an online version that we had developed with the guidance of our advisory group. And following their suggestion to use Miro, an online whiteboard software? Did we devise this version of the card sort time task? And everybody who took part in the study chose to take part in this way. We talked, as part of that process, we talked to people about our access and technology preferences, about safety, and they accessed a version of the card sort task that looks a bit like this. So on your screen now, you should see the time points across the top. And this is just an example version, but the different colours represent whether a card is a thought, a feeling, or behaviour. And so what you can do then is analyse the data to look for patterns. So I'll just show you one snapshot of the results for the from 29 autistic and possibly autistic people who completed the card sort task for self-harm, describing their most frequent experience of self-harm. So what you get from that is a sort of map like this, so which shows patterns in the data, and in particular it shows the number of times that one card precedes another beyond the realms of chance, if you like. Now it's a little bit difficult to see, but I'll try to but yeah, it shows us here, these yellows are all emotions, this is support, this pink one, and the green ones are actions. And what I've done here then is just to highlight, or to try to identify the key transitions that is shown in the data. I just think I need to just do that. So what you could see there, which was a little bit difficult to see, is actually that the build-up of these really difficult emotions, of feelings of entrapment, feeling like a burden, unable to escape, or worthlessness. And then it's this key transition here of not being able to tell anyone how I was feeling that can either lead to, that is then followed either by agitation and restlessness, or having access to the means to self-harm. And Bill brings that sequence of acting on impulse, self-harming, feeling better and worse afterwards, and then hopeless and exhausted. And sorry, that is quite difficult to hear, but I think the important point is actually it really highlights the importance of being listened to and understood, and the power of that. It raises with us a question about the role of restlessness, and really important, as Rachel was just saying, about the role of hopelessness, if actually this is one of the things that happens after self-harm. But as I said, this is very preliminary work in progress. And the other thing that we will be doing when we analyse this data is looking at the handwritten cards that were provided by autistic people, and analysing whether there are particular themes coming through in that allow us to better and more accurately describe the experiences of autistic people. So, and then finally, I was going to talk about the Autism Adapted Safety Plan project. This is another study that I'm working on. This is led by Professor Jackie Rogers and Dr. Sarah Cassidy. And this is a very large team on this study. I am one small representative, but I thought it'd be really helpful and important to share this given the substance that we're talking about today. And in this study, we're evaluating the feasibility and acceptability of using suicide safety plans that have been adapted to be more accessible, more useful for autistic adults. So suicide safety plans typically contain these components. It's a simple set of hierarchical steps that a person can walk through to think about possible options in the event that they experience suicidal thoughts and behaviours. It is typically a written document, though it can exist in other formats. And it's potentially helpful for autistic people because of its structured nature and because it is personalisable. And even when used with non-autistic people, the point about it is that it is about understanding the individual's preference, the individual's preferred coping strategies, and it's written in the person's own word in collaboration with somebody else. So this is a 3-stage study. I'm just going to talk about the results of stage 1, which was a series of focus groups that were held, which were held with autistic adults, family members, and professionals from support organisations. 32 took part to consider how to adapt safety plans to be used with autistic people. Some of the things you would find here would be, as you would expect, to ensure the language is clear and concise, avoiding double negatives, avoiding double meanings, avoiding too many instructions at once, and support to name emotions and helpful resources to kind of provide the bedrock to be able to fill in the expectations of the safety plan. And one of the concrete suggestions was to change the name of the section of the safety plan that says reasons for living to be what is important to me. And then some further findings from the focus groups about how to get the most out of the safety plan, with some really helpful suggestions here. So in particular, acknowledging the previous difficulties or traumatic experiences the individual might have had accessing services, ensuring that the person has enough time and space, that they're sufficient, that they're in the right emotional space to be able to complete the safety plan, and ensuring that the autistic adult has the right supporter around, someone that they trust sufficiently to undertake that collaborative work, or someone who is prepared to engage in building that trust. And I think just again, some things that reflect how safety plans should be used anyway, that the importance of choice and that it should be a flexible document. So that's all I'm going to say about that study now. Just to say that is a 3-stage study, and we're currently analysing the results of stages 2 and 3 and planning the dissemination of that, and the results of that study and the autism adapted safety plan should be available sometime in early 2024. You can follow us on Twitter, or you can email if you want to be kept in touch with those results. And then, as I said, this is a very large project, so just to acknowledge everybody that's been involved with that. And then I will stop sharing and hand back to Rachel.
Hello, my name is Georgia Harper. I'm Policy Manager at Autistica, and today I'm just going to very quickly take you through some of our work on suicide prevention so far and what we would like to see in suicide prevention policy for autistic people going forward. So, looking at our work to date, this area really came to the forefront of autism research in 2016 through research carried out by Harper in Sweden that found huge prevalence of early death more generally across autistic people, but in particular high rates of suicide in autistic people who do not have learning disabilities. Our report, Personal Tragedies, Public Crisis, really helped put this issue on the map in the UK. It did make various headlines at the time, but more importantly, the autism strategy refresh that followed from that in 2018 in government had the overarching objective for the first time of reducing the gap in life expectancy for autistic people. This essentially was also echoed in the NHS long-term plan the following year, which adopted our vision of autistic people living happier, healthier and longer lives. On a more practical note, in 2020, Autistica were commissioned by NHS England to create an evidence-based resource for crisis workers, helpline workers, that sort of thing, on supporting children and young people who might be autistic and who are using their services, so they're in distress, might be thinking of suicide. This resource focuses on practical adjustments, such as recognising when the person you're speaking to might be autistic, changing the way that you communicate and the language you use, and just recognising their responses might not necessarily be what you expect. The resource is available on our website. It also delves into some of the factors behind an autistic person's distress that non-autistic professionals might not necessarily think about. Of course, most of what we do is research, and over the past decade, Autistica has supported a range of studies looking at tackling suicide in autistic people, from assessing and treating mental ill health more widely, to things like testing the assessment tools that are used to risk assess for suicide, and often they are not designed with autistic people in mind, so looking at how those can be adapted. In particular, we funded the psychological autopsy study led by Sarah Cassidy at University of Nottingham. This study essentially looked at coroner's report in different areas of England to assess whether people who had died by suicide might be autistic. Of course, most autistic people do not have a diagnosis. That study found that up to 11% of people who died by suicide could be autistic. That is a huge overrepresentation. Of course, we need further research on the true prevalence of autism, but we think about 1 to 2% of people in general are autistic. So to account for 11% of suicide death is a huge overrepresentation. So where do we go from here? Well, at the time of recording, which is a few days in advance of this webinar, the suicide prevention strategy is out any minute now. It may well have already come out at the time of this webinar. That is the kind of government's overarching strategy for suicide prevention, and autistic people are likely to be recognised as a high-risk group for suicide. So that is a huge step forward compared to where we were even 5 years ago. But of course, we need to support autistic people before they reach a crisis, rather than the typical thing of only intervening after something has gone wrong. And a lot of our work today is kind of, I guess, further upstream, looking at how autistic people can be supported to, have better outcomes so that they do not reach this awful point. So these are our 2030 goals. You can find more information about these on our website. There are also more detailed commitments and recommendations for most of these goals on our website. Right now, it is difficult for autistic people of all ages to even get a diagnosis. And for those that do, there's still no support at the end of it. Nothing has changed there for decades now. We are calling for really a bit of an overhaul of the assessment and support system, clear pathways for support across the lifespan, again, before a crisis is reached, and more effective therapies for mental health, particularly anxiety-related problems in autistic people. Our other 2030 goals will link into this too. We know that there are links between unemployment and suicidality. Inaccessible public spaces cut autistic people off from not only work and education, but the activities that they enjoy, and that all has a knock-on effect for mental health. And poor access to healthcare leaves autistic people's needs to escalate to this crisis point. And of course, a huge factor in all of the above is outdated and hostile attitudes that autistic people still often face. Changing these outcomes requires research. Too often, professionals are left guessing on how to support autistic people with no clear pathways commissioned. Hopefully you've seen by now the impact that the work Mirabel, Rachel and so on are doing can have. We're calling for more of that, essentially. We're calling for a single national strategic initiative for autism research, which was promised in the 2021 autism strategy, and in the meantime for clarity over support pathways, particularly for autistic people who are experiencing mental health difficulties, who we know are often just pushed from pillar to post across different services that don't know how to support them. That's it for me. Really sorry I can't be there in person today, but if you do have any questions, please feel free to get in touch.
Thank you everyone for listening to that video, and I'm going to move us forward now, if I can. That was the end of our two talks, or part two. So I just want to leave you with our contact details. We are going to move on to some questions now, so not to worry about that. But here are the contact details for both myself and Mirabel. The QR code in the corner is for the resources section of my site that I mentioned before. But we're going to now answer some questions. And any questions that we don't get to, we hope to answer in a written format later on. So just to say a huge thank you on behalf of both of us for listening to our second talks. And we'd love to answer some more questions now.
Thank you both. I'm just going to get my question up. So, I've got one question here. Have you identified an increased risk of suicide or suicidal thoughts amongst adults who are going through an autism diagnosis, since the diagnostic process itself can be quite traumatic?
I'll start then. So we haven't, but I think the asker of this question has hit on a really important and valid point. I think the thing what makes it difficult in part to study this particular group is that before someone has an autism diagnosis, it can be quite hard to get them into research studies. And likewise, if someone goes through a diagnostic process and they don't get the autism label, then they kind of go off and they're not recognized to be autistic, and hence they don't really get into our research studies, and that's really, really problematic. But there has been some really good work around looking at mental health and suicidality in people who are autistic and possibly autistic. And so the kind of things they find is that people who identify as autistic but who haven't yet got the label officially do seem to have mental health difficulties as severe. They're struggling as much as diagnosed autistic people. So do you want to add anything on that, Mirabel?
Yes, I can add on that. So, yeah, just to support what Rachel had said, in fact, in the model that I proposed in the first half of the session, in fact, that model does include people who are possibly autistic, as well as people who are confirmed diagnosed autistic. And in fact, the particular data-driven approach that I could use there showed that the people who did not have a formal diagnosis, their data operated in the same way as those people who do have a formal diagnosis. So, it is really important that we include them in our studies. I agree with Rachel. People going through a diagnostic process are probably worth, I hear reports about that from clinicians, certainly, but I think probably the thing that is in research, that adjustment and change are likely to be, proximal risk factors if you take the framework that Rachel was describing earlier. So it would, and that is a significant life-altering change. So certainly it would be a likely candidate.
Thank and someone's asked about the impact of the loss of family support, because families are often the main support for autistic people, but parents cannot be around forever. Siblings may go off and lead their own lives. So how much does the loss of parents or major family connections impact on suicidality?
Do you want to start with this one, Mirabel? Oh, you're on mute.
I was just saying you can go ahead if you're unmuted and ready.
Oh, okay, I'm unmuted and ready. We don't know the full impact. Statistically, the research hasn't been done to really show us impact. Those a few relevant findings are, you see across the population that rates of suicide stay quite high in autistic people. Though typically suicide rates decline with age, that doesn't seem to be the case in autistic people. And that could reflect something of what you're saying, that people are really struggling once they get into later life and maybe they don't have their parents around. And intuitively, you can see quite an apparent relationship between, you really do get a lot of support from your parents for some of these things that might be distal risk factors. So maybe if you struggle with emotion regulation, I know I do, I get a lot of support from my family. So when you no longer have that support, that might be really difficult. And likewise, you can see how if you get a lot of sort of social support, belonging from your family, that can be really difficult. So we don't know the answer specifically, but we do know that suicide rates, they stay high and are high in older autistic people. Would you like to contribute?
I think I think, again, it's another really important area to look at in the future. I mean, I think your lifespan research is just really, really important and really, really challenges lots of assumptions about who is at risk. But I think just to mention that we do know that having unmet support needs is a suicide risk factor. So if your major support was your parents, then you now have a recognised suicide risk factor, and you've gone through a deeply traumatic loss and experience. So, yes, very likely to be both that combination, as Rachel was saying, of distal and proximal factors.
Thank you. The next question is around autistic practitioners. What are your thoughts on the value of autistic practitioners supporting autistic clients? Does this make a difference to the quality of the relationship and the recognition of suicidal vulnerabilities? Rachel,
you want me to start?
Sure.
Okay. So again, I think there isn't a lot of research out there. And I think to an extent, very sadly, this reflects that until recently, there hasn't really been a lot of recognition that autistic people might be counsellors, or they might be therapists, they might be doctors and so forth. That hasn't really been recognised and looked into. What seems to be emerging from the research, though, is that in line, as Mirabel mentioned, the double empathy problem, autistic people often seem to get other autistic people and they feel maybe more comfortable interacting with them. There might be less stigma there, less perceived stigma. You might feel safer with that person. You might feel more understood. So there is research that autistic people communicating with other autistic people, that can be more enjoyable. They can feel more supported and understood. But there isn't really research out there to say that autistic therapists and counsellors, when they're working with autistic people, are more helpful, if that makes sense. And we know that post-diagnostic and peer support can be really helpful, but there just isn't that research that really tells us autistic therapists and counsellors are more effective than non-autistic.
Do you want to add?
Can I just add that maybe if anybody has had a really helpful experience where having an autistic therapist or a therapist of their own neurodivergence, then they could put it on the Padlet, because that would be helpful to know. I think, in theory, it should be helpful for given the research that describes that autistic people have better have stronger intersubjectivity with other autistic people, you would imagine that would lead the therapeutic relationship to form more quickly. And one of the things that is documented in research is autistic people needing more sessions at therapy because it takes longer to establish the relationship. Well, would that be the same if both practitioner and client were autistic? I think that's the only thing I have to add. So let's go on, because there's loads of questions.
Right.
Yes, please do put it on the Padlet if it's something that someone has had a positive experience of, because that would be helpful to know.
Right. You're right, there are lots of questions, but we've still got a bit of time. So I'm just going to move on to one around learning disabilities. So how do you support autistic people that have accompanying learning disabilities? They too have mental health needs, but can slip under the radar in some of these studies.
Well, I'm happy to start, but I think we're probably going to start by saying that the answer isn't immediately available exactly how you support people. I mean, I think the studies that I've presented have particularly included people who do not have an intellectual disability, because they're perceived to be at increased suicide risk compared to people who don't have who do have an intellectual disability. And I think since I've done my research, that the research is more nuanced now, and actually that people who are who have moderate intellectual disability may actually be at increased risk. And anyway, we know that people who have an intellectual disability are often overlooked for autism, and their needs are often not met. But But I'm afraid in terms of exact guidance, that's probably what I can offer. Do you have it? What can you offer, Rachel?
I'm afraid I'm in a very similar boat. My research has mainly entirely focused on autistic people who were able to self-report their experiences. So it's in terms of suicidality in autistic people with an intellectual disability, as Mirabel said, we know it is more it's more common that people will struggle with their mental health and suicidality than, for instance, the general population. But as Mirabel said, how to help is always the area where research is a little bit behind. We tend to be better at understanding something, and then the practical side kind of catches up. But I do think that, and the comment that's just been said, that people can self-report, absolutely they can. Absolutely they can. So I guess I interpreted the question as maybe people with a more, I can't think of the word, who might not be able to respond to a survey. But yeah, we really need to know more about how to help.
Yeah, and we know that they're overlooked in autism research in general.
Yeah.
So, I mean, it's definitely very important and a more nuanced picture than we just have people with and without intellectual disability. I think there is work ongoing. Again, I think Sarah Cassidy has a PhD student looking at self-harm in people with moderate learning disability. But that's work ongoing at the moment.
Thanks. I think we've probably got time for one or two questions, depending on your answer to this one. Has there been any research and outcomes for autistic people who have attempted suicide but survived?
I know of one study. Is that all right, Mirabel? It's not published yet, but I know of some very important work that's ongoing in the States, where they are interviewing people who attempted suicide and survived. So this research is being done by Dr. Anne Kirby. I don't believe it's been published yet. I think it's a really important area. Do you want to add anything, Mirabel?
I wasn't aware of that study, so that's very helpful.
On the point of things not being published yet, I think Georgia in her presentation mentioned the suicide prevention strategy, which actually has now been published. So we'll be able to share with those, especially on email, those registered on Eventbrite. So I'd mention that.
Can I just add on that the research that I've outlined has been included in that strategy. So people who took part in the research, really huge thanks. But this is a real example how taking part in research does then get directly into government documents. So really, real thanks. Really important. Thank you.
Okay, I'm just going to squeeze in one more question, which is around the topic of belonging. This person said, is belonging the same for autistic people and non-autistic people? And they've asked this because they find belonging a word they can't identify with.
Oh, well, I'd really, really love to speak on this for the next hour and a half, if anybody got time. But no, seriously, that was what I was, that's what I found in my study, that the way that we describe autistic belonging for non-autistic people isn't meaningful for autistic people. And I then went on I managed to get some funding from Coventry City of Culture to do a creative study project, which was just designed as public engagement, which allowed people, what I wanted people to do was just to describe in belonging in any terms that are meaningful to them, either in creative methods, or they could fill in a postcard or draw a picture, anything at all. If you go to my website, you can see what happened with that project. But actually, it was very different in its reality because of the pandemic and because of the funding timescale. But what we will be doing in Coventry this November is getting that project alive again as part of the ESRC Festival of Social Science. So again, if it's all right, I will share that in the resources for this webinar, and it's something that you can get involved with because I would be really interested to hear your views on that.
Absolutely, that's great. Rachel, did you have anything to add?
No, I don't think so. I think Mirabel said it all. I think the bottom line is we don't know, and we need to know. We need to know.
Fantastic. Well, it sounds like there's lots of things that we're going to be sharing after this. And as I said, those that registered on Eventbrite will be sharing lots of those resources in the email. And then on the YouTube recording, we'll see what we can fit into the description underneath in terms of useful resources and odd links for people. But I'm afraid that's all we've got time for today. And I'll try and wrap up quickly because I know we're out of time. But thank you so much for all of your questions and all of your contributions. It's been a really amazing session to dig deep into such an important topic and sort of bring this research back to sort of real people's experiences. And as I mentioned earlier, if you need to take a short break after this, do whatever helps you. Go for a walk, have a cup of tea, and just helping you sort of reset. And if you need to speak to someone, call that trusted person and speak to, and do sort of reach out to one of the Samaritans and to talk, because we know that this is a very difficult topic. And you can also refer to the resources that we've shared in the chat and that we've shared via email session. If you want to take part in research like this, and you're not already on the Autistic Network, do go onto our website. I think a link will be shared with you where you can join the network to hear about future webinars, research you can take part in, and also results from research that's happening across the UK and beyond. So all that's left to say really is a huge thank you to Rachel and Mirabel for your time today and answering all of those questions so thoughtfully, and for agreeing to follow up with people after. I think that's incredible. It's been an absolute pleasure to have you with us today. And I think this is a record for the number of people that have attended a webinar, which just shows the real need for more sort of information in this area. And as we've talked about today, more research as well. So thank you so much to our speakers. Thank you to everyone that attended. And we look forward to seeing you at future webinars. Thank you very much. Bye-bye.